but okay. So I have to admit I'm a little bit under the weather today. I actually took today off because, well, it was a long night of nausea, vomiting, shivering, and soreness and all that jazz. Because my older son had it about a week ago, and younger son had it a week before that. And I don't know what this one is. It's taken a week to present itself, but fun day. But this show must go on, so here we are. If for some reason I mute or turn my video off, give me 30 seconds. I'll be right back. There's a bucket right here. Hate to mention it, but that's what we got to do sometimes. So let's go and make it so I can see my slides. I guess turning gears a little bit, we're going to talk about cannabis and cannabinoids. Um, didn't come up in the three cases today. I was really thinking like, hey, there's three cases. I mean, statistically speaking, it should come up, right? Um, but always got to keep it in mind. Hey, if anybody's speaking and they have disclosures when it comes to cannabis, raise an eyebrow or 12. We're going to go over cannabis and cannabinoids. Pretty straightforward, right? All right, so there's the starting big picture before we, put our clinician hats back on of any type. But finances and then laws, regulations, all that great stuff. So, all right, so everybody's typically seen the headlines. I updated this recently of like, oh, this whatever you want to call it. I'll have a slide later for words and picking out the terminology, but marijuana tax revenue. When you see headlines of like, oh, California, $300 million. I mean, I just did our taxes yesterday. That would have helped me out last year. But I'm not running a state. I'm running one building here in West Virginia. So another way of looking at it is just to balance things out, not a budget, but the percentage of a given state's budget. I volunteer within our parish on finance council, and it's like, man, the budget is much different than any of ours, presumably. But you're usually talking much bigger numbers. And here you see, like, even that California 300 million, well, it's like a fifth of a percent of the overall budget. And I'm not going negative with it. It's just, we saw this within opioid overdose death numbers back in the day of, you want the percent population. That's good. You also want the raw numbers too of actual heartbeats lost because, you're dealing with illegal substances crossing a border. It's a little bit different to the numbers of, Ohio, large population compared to us. But this is just kind of calibrating of, it's not just the headlines of the money. And well beyond this group, there is the court of public opinion. Based on numerous observations, the ship has sailed. And typically in these presentations and conversations, it's not always what people agree with. But public opinion is out there and pretty strong, and not even political or anything like that. I usually like to bring this up from Dr. Nora Volkow. She did this at a university graduation commencement, ended up in an article as well too. But to summarize this and not just read it, legal drugs, alcohol and tobacco, really give us a picture of its access that also comes into play beyond mechanisms of action and dose and price and all that stuff. Although price is part of access, I would argue. But it's that regulation status certainly can matter along the way. Preaching to the choir here. Maybe it's the pharmacist in me, maybe it's the wannabe JD, but the plant is not the same thing as what's in the bottle, as per the FDA. I don't even think they'll dispute that anytime soon. It's just different. It doesn't mean that there's not THC within the plant. It just means that you know the dose in that bottle towards the right there. So our controlled substance classes, about 1970s, so like 55 years ago, we had the Controlled Substance Act. It's the first time I said it this year. Man, 55 years. So for 55 years, we've had this classification system of 5 levels. And we haven't had any drug problems ever since we made this, right? There was a lot of decisions that were made back in the 60s, 70s, and we can go on for hours, and you guys know 120% of it all. But this is how we roll. And there's different, these are all based on there's like 5 to 7 qualifiers, but the two main ones are to distinguish the controlled substance classes would be generally accepted medical use and then abuse potential. Those are the two big ones there. So a C1 being illegal because there's said to be no generally accepted medical use. So currently we still have cannabis in there, but not CBD because of the Farm Bill and all that great stuff. Um, re I won't jump ahead of myself here. So here, this reference is not perfect because I don't think there'll ever be a perfect one, but it's about the best resource I could find out there, and I usually update it every 6 months or so. About 2 years ago, it was like every week, but um, of just showing like, hey, what are individual states doing when it comes to all things cannabis, as far as regulations or lack thereof or whatever. And you could jump back towards the left here and see all the way back in 1996, California started the ball rolling, and now we have all these shades of green and a little bit of orange in there as well too. And when you look, if you were to go to this site, there's going to be some nuances here or there. I will say that, but it's probably about one of the better ones to kind of, start the conversation. I've learned in these presentations to add a slide because you never know what the heck headline's going to come out today or this morning. I got it easy today. There's no huge change in this regard. I think we got enough other stuff going on that they're not looking at cannabis directly right now. But in the background, I'll keep this slide because there's probably something coming relatively soon. Of course, we said that last year too, but it was a little bit different situation along the way. All right, let me check the chat here. Oh, okay. Well, thank you for the sickness part. So, TBD. We'll see where we go. Big picture though, I used this once before, even in this group. Regardless of what we or any country, state, or whatever ends up doing, there's interesting ways of looking at, regulation. It's typically the like, hey, is it legal or not, or maybe decriminalizing. But the thing that's interesting about this particular chart is that it's looking on the y-axis at harms to both the individual and society, but you can just call it harm, right? And we already had the words earlier where we're all about harm reduction. So, somewhere, and this isn't saying go right in the middle, you don't have to hit the bullseye. The point here is if you go stringent or you go wild, both of those will typically, for any substance or activity, result in the most harm. Somewhere in the middle is where we, typically want to aim. We'll see. All right, so that was the dollar signs and regulations and all that, but let's pull it back into perhaps the clinical or at least pharmacological side. So the ECS, I still am baffled that I'm holding out hope. Maybe not my oldest son, he's in second grade, but Leo, the youngest one, he's just in daycare, so there's hope. I'm really hoping that like sixth, seventh, eighth grade health classes start covering this thing. And I know, I see faces. I don't hear people, but I see faces. Um, you'd be like, whoa, why would you want that covering with kids? Well, information is power. It doesn't mean that you're saying, hey, this is something that's part of us. Like every other system within our body. All of our body systems work together or overlap at least to make us who we are, make the whole machine work out. The ECS, the endocannabinoid system, is one of those. So we'll see if health class changes. And here we'd be like, well, do we cover it in MD, PharmD, PA? Typically. So the ECS, there's like three main parts. I'm really whittling it down here. But there's receptors, of course. There's enzymes, builders and breakers. And then I'll go a little bit deeper with that CB1, CB2, but receptors. But everybody's heard of those things. I usually say that the physical numeral one is tall and skinny. So that's usually, you can remember it's in the CNS, whereas the numeral two is wider. So that's typically out in the periphery, give or take a little there. There's these other receptors that are involved in the ECS. And then there's the enzymes. You could see the first and the third, it says biosynthesis. Just call them the builders. And then the second and the fourth are degradation, or they're the breakers. I really should just say builders of breakers on here because there's way too much info on here. My bad. But um, they're building up or breaking down endocannabinoids or cannabinoids that are put into our system. Here's the two most well-known endocannabinoids. I got rid of the structures because Very few want or need to see those. But you got AEA, an anandamide, and then 2AG. Sure, you'll want to go with the abbreviation there on that one. These are the ones that are naturally floating around in our body. Our body, makes these things and breaks them down as well with those enzymes. So that's what's in our bodies. Keep in mind, it's similar in cardio. We think in pulm, we think alpha, beta receptors. Same thing here. We even call them one and two because we don't get too wild on our terminology. But as far as the cannabinoids go, um, and there's these days a lot of people like to have random information that conflicts with some of this, but this is the tried and true for a while of, what are the mechanisms for THC compared to CBD? It's not that they're polar opposites, but they're a little different. So one of my least favorite words in pharmacology is partial agonist. At least two-thirds of you, your heart just sunk because you're like, oh my gosh, we use that term for buprenorphine, and it confuses the heck out of everybody because it's like, well, does that mean it's a wimp? No, it just talks about how it interacts, the key in the hole. It's a little bit different. Leads to some, ceiling effects with buprenorphine. That's a good thing, but it just interacts with the receptor a little different. You're still going to get the efficacy along the way. So THC does that with both CB1 and CB2. CBD, it doesn't like CB1. It's an antagonist. So it blocks it. It goes on it, blocks it. So that's the opposite of THC. CB2 is a negative allosteric modulator. What in the heck is that? It's a backseat driver. It's about the best one I could come up with. I think I've said this before too. So it binds to a secondary site kind of next door to the receptor and calms down the response of an agonist there. It's literally a backseat driver. They're in the backseat, they're whining and complaining, giving negative outcomes to the driver. It's a backseat driver. So you could also remember negative allosteric modulator. That works too. All right. So we're running through here. How are we doing on time? So CBD products, they're certainly everywhere. You don't even need all the neon signs anymore. They're just everywhere. There's the three main types. And this gets me. The next like 3 slides, I'll have a couple studies talking about labeling accuracy. But oftentimes and I'd even pick on those studies to say, well, what was the type of product? So for CBD products, you have full spectrum, broad spectrum, and isolate. Can't tell you how many pharmacies I've walked into. I promise you, I love my fellow pharmacists, but um, I'll walk in eventually and be like, hey, who picked these things that are on the end cap? The CBD products, typically locked up too. And they're like, box shows up, we put them out there. Really? Well, it could really mean a lot because full spectrum could have all cannabinoids. So it's a CBD product, but it could have all the rest of the gang, including THC. That could get a little tricky for somebody's, work urine drug test screen or whatnot. Broad spectrum would be all the cannabinoids, including CBD, but not THC, as per labeling. And isolated, of course, is labeled to just have CBD. So you got FBI. That's hopefully a way to remember those. All of that being said, though, labeling accuracy concerns still exist. And I'd like to respect the mic. I'm not giving opinions. Let's give some reviews here or studies along the way. I promise the latter ones are a little bit more recent. But this is back from 2017. What I want to show here over about 3 different studies is that things are improving. The accuracy and labeling across the board for the market is improving, but it's still not there for what we're used to with the products that we utilize in clinical practice. So you got a lot of different products here, almost 100, and 2/3 of them did not contain the CBD amount reported on the label. Yeah, that's not too good, right? Well, it might be off a little bit, it might be off a lot, Then we had a couple years later, here was an FDA study. It kind of complicated, goes over a whole bunch of different years, but and this is where it gets a little bit murky. So this, if you looked onto the last bullet point there, the 2019 with 31 products tested, and like about half of them contain THC. Well, I can go back. Was it a full spectrum product? Because that's what makes sense, right? Now, if it was a broad spectrum product, it shouldn't be like that. And I looked through them and they didn't have any info, probably because they didn't know about the different products. Not they as in the organization, but just in general when they're writing these things. So, all All right, here's the mo more most recent one I've got today from just 2, 3 years back. Um, this is more bullseye like. So if the on the left here it's percentage and on the right it's milligrams for CBD within the product, it's saying how accurate was it, and they're basically saying you got to give a little wiggle room. So on the left here, all those little clear or white circles are deemed acceptable. Sorry, the darker ones that are much higher percentage or much lower are unacceptable as per the authors and dare we say common sense. It gives a really good picture here, but think about the story within it too. What if you're one of the you're a CBD product manufacturer company, whatever, and you're one of those clear circles. You're doing it. You're nailing it. Good job. But you get a bad rep because of the other ones on the market, and vice versa if you're one of the filled in dark circles, right? It's getting there, but not quite there yet, right? I couldn't find anything at least as aesthetically pleasing as that one, as far as updates. So we still have that to go by. All right, so that was CBD. Let's go to THC products. Oh yeah. Joint, blunt, spliff, hash, and hash oil. Not everyone woke up today thinking this is what we'd be talking about, right? Well, most folks know what a joint is, but a blunt, that's a little bit thicker, right? But a spliff, now you're talking like tobacco and cannabis together in the rolling paper. And you wouldn't be able to know it because looks like a joint, basically, or a cigarette for that matter. But these are your different ones here. Now, the ones towards the right with the hash and the hash oil, that's where we get a lot more potency because it's just extracted along the way, and that's where concerns really arise. Speaking of concerns, so is this a concern? Actually, it's concern with an exclamation point. So I've actually showed this to my oldest son and I was like, what do you think about this? I told him what was in it. I run all my slides through elementary school kids. It makes it so much easier for the rest of us learning. He had some qualms with some of the other ones, but this one he got. It's like, yeah, it looks tasty. Looks fun. Ugh, I got a lot of work to do, huh? We all do. These things are out there. It's not doom and gloom, but it's a reality out there. It's called read the label, right? And we're not worried about the nutrition effects necessarily, but it's a reality. It's out there. We just have to have those conversations, right? You don't necessarily need to use slides with pediatric scenarios. All right, Delta 8, you've seen it on every corner of every block in America, particularly here in Mon County, because we have the highest rate of dispensaries per county in the country, or at least we did. So Delta 8 is just fancy terms. It's an isomer of Delta 9. So Delta 9 is the usual THC. And I tried to highlight in the top right here. You literally just, if you look that double bond, it looks like an equal sign. You just shift it from the left on the Delta 8. Yeah, put it on the right for Delta 9. Of course, you're going to have some changes in effects and safety for that matter. Like anything else, add a methyl group here or there, and you can change a lot. But it's not huge. It's a subtle change there. But said to not really have as much action going on. Whereas, where do we go here? I thought I had the THCO acetate. That one has a lot. They changed it a little bit more, and that one has a little bit more oomph, for not using a pharmacological term, to its utilization. All right, so jumping further into the clinical utilizations, words matter, grammar matters, spelling matters. I don't always excel at all of them, but cannabis-based medication. I think I'll have a slide on it of the like 3 FDA-approved medications. They have cannabinoids in them. In fact, one of them is extracted. It's a natural product, comes right from the plant. It helps a lot of kids with a lot of seizures. Then we have medical cannabis. Some folks like to say medical with quotes, but they're not the same. They're different terms along the way. Again, looking to avoid opinions and all that stuff, but it's just how to go about talking about these things. So I'm sure folks are familiar with in our state, the Controlled Substance Monitoring Program, or CSMP. or every state calls it something different, but the Prescription Drug Monitoring Program, uh, tracking all the controls dispensed in our state based on pharmacy dispensing. Usually live within 24 hours. The computers take care of all of it. There's not one of these things for, there's limits for what somebody can buy at a dispensary, but there's not a limit saying, okay, you bought your maximum here. There's another one 2 blocks down the road. They don't know what you got. This isn't rocket science, and I'm not insinuating that everybody's doing this. So let's not sensationalize the heck out of everything. But the point is that it's a thing. It's possible. Okay. We're not seeing huge reports on that, but it's when we're thinking about what could we get folks in charge thinking about, here we go. Of course, there's patient privacy concerns along the way, being fair to the other side of the coin. All right, here's those three prescription FDA-approved products that are cannabinoids. You basically have dronabinol or THC in two different forms here. You see the little roll-around capsules and then the liquid. Different controlled substance classes may be obvious because liquid, you could have a lot more going on there. But then you have the extracted CBD product, Epidiolex, for three different specific pediatric seizure conditions. It was a controlled substance, and then one right around the time of the Farm Bill, when being approved, it got rid of the controlled substance class because it's CBD. Remember, it's a backseat driver for CBT2. All right. I haven't seen anyway, more recent review articles because I think they already banged the drum home on this. But here's an interesting one because it comes from the American Heart Association. And if you're like me, you're thinking, why aren't they staying in their lane? Why are they trying to figure out what's potential cannabinoid utilizations? Sorry. But well, when you think about it, there's cardiovascular concerns with cannabis and cannabinoid utilization. So they actually are in their lane. And somebody's got to get this done. So I tried to color code this. There's a lot of things that would said no randomized controlled trials, maybe. And then you know what? There's actually conclusive or substantial evidence, as per the authors, to say that well, for pain, cachexia, nausea, and vomiting, MS, and epilepsy. If you think about it, that's where we already see approvals for prescription products, either in our country or outside of our country. So it's not reinventing the wheel there. It's just, they went through the different articles. Then we could always have the age-old discussion on urine drug screening. And here I, of course, mean the screening, the cheaper cups, really quick results, not the testings or send out results. There's potential false positives, and I always want clinicians to know this because two of them are over the counter. You got ibuprofen and naproxen. Um, if I wanted to mess with you as a fake patient or something, fake shopper, I'd have you run a urine drug screening on me, and then you'd be like, "Hey, screen positive for THC," and you'd be like, "I forgot to tell you, I was gardening the other day. I went down to Dollar General and I got me some of the ibuprofeno, and forgot to tell you." And I looked it up online, and it looks like that could be a false positive. So, what you think? And of course, then you would run the urine drug testing and you would know for sure. But what if there's little timing concerns, things like that? Now, as far as the structures there, they are very similar in the 2D, but if you go 3D, third dimension, they're said to be a little bit different there. Here's one study. It's not profound, just showing where the false positives for urine drug screening cups. It's about 1 in 5 scenarios, according to this study, could have false positives or false negatives. And those are concerning, obviously. As far as interactions, I call that job security. It's I think we had Ken was here like a year or two ago, and I remember he said, "Oh, we're up to like 600 documented interactions for cannabinoids and cannabis." Yes, like every other medication, there's a lot of drug-drug interactions, but which ones are clinically significant is where it's at. A lot of the CYP 450 ones don't matriculate into the significance in most cases. There's my little lawyerese. Protein binding is a thing. So if it's binding to protein floating around in your body, then the interaction will typically be significant. We had the one medication, it was divalproic acid, but here it's valproic acid. It's not tomato, but pretty close. that's like the case study go-to of warfarin, valproic acid. They're clinically significant. And if you're talking about THC, obviously sedatives. You didn't need me to talk about that. Adverse effects, common sense ones on the right. Cannabinoid hyperemesis syndrome on the left. That's, people taking a lot of like a dozen hot baths or showers a day because somehow that helps, probably because of the TRPV1 receptor and all like where capsaicin works. But that's certainly a concern along the way. And getting closer to wrapping up here on time. When you look at harm, there's overdose deaths. We got a lot going on. That drug one, actually, I believe it was last week, just updated, where they actually published it on the little charts to say that we're down to like 90,000, 80 or 90,000 for drug overdose deaths in our country. So that's progress. Still a large number. But marijuana doesn't really factor in much there, all respect to those 18 heartbeats. But ER visits, it certainly does along the way there, of course, too. So that's a big thing there as well. So, all right. The joints have changed. Products are much more potent these days, and we have to keep that in mind as well too. And here's just a comparison down towards the bottom of a dronabinol capsule being a little bit, and joints up here being a lot more. And then you have extractions that are even a lot more. So big leaf, great grief. And big picture, perception is said to be everything. Um, I find it interesting how they would have pulled this study off, but they made a nice chart. When the perception of risk is higher, pun always intended, utilization is down. When the perception of risk is lower, utilization is up. It makes sense, and that's illustrated here basically. So the education, the conversations really do matter is what it's saying. Key takeaways, everything. Feel free to check out my website, I guess. Let's see here as far as
We
chat-wise.
have a question. Yes.
Let me pull that up here. I'm going to
It says,
actually.
how common is nausea and vomiting induced by long-term or high-dose use of THC?
So I might be going on a little bit of a limb here, but it would be mm, expected to be more prevalent because the higher dose, it's paradoxical because it can produce it but could also treat it. And then that comes into which cannabinoids are actually in the product, which we don't always know. So I'm not looking to sound confusing, but the landscape is confusing along the way. But with the higher potency products, which are relatively universally available now, that is certainly a concern. Like acute psychosis is another thing too, where that has observed rates of that have increased a lot because of the higher potency products. Boom.